For decades, the pathological hallmark of Alzheimer's, extracellular protein plaques, resisted pharmacological clearance. That barrier has now been crossed. Agents like lecanemab and donanemab represent a major clinical milestone, enabling the targeted removal of these protein clusters from the cerebral cortex. Empirical data from the Clarity-AD and Trailblazer-ALZ 2 trials confirm that this clearance produces a measurable benefit, slowing clinical decline by roughly 25 to 35%. Plotting these efficacy curves against disease progression reveals a strict ceiling. Treatment slows decline by a maximum of 35%. The red shaded area represents the remaining 65% of unmitigated cognitive collapse. The disease continues even after plaques dissolve. This 35% ceiling reveals a critical limit. Clearing amyloid only slows the cascade. The majority of the neurodegenerative collapse is driven by separate, parallel mechanisms that continue to destroy the circuit even after the protein plaques have dissolved. The spectrum of collapse framework defines Alzheimer's disease as 3 biologically distinct, sequential pathologies spanning several decades of the human lifespan. Phase 1 begins with a silent bioenergetic erosion of brainstem neurons between ages 20 and 50, setting the metabolic conditions for later failure. This timeline isolates Phase 2, a window between ages 50 and 65, known as the hippocampal bridgehead. Here, the pathology breaches the entorhinal cortex and the hippocampus proper. Deploying an anti-amyloid drug during this window addresses only one upstream trigger. By this stage, independent cellular failures have already activated, ensuring the circuit will continue its descent into terminal collapse. To understand why these mechanisms persist, we have to look at the cellular architecture of the CA1 pyramidal layer within the hippocampal bridgehead. This demonstrates pathos. Internalizing extracellular amyloid beta protofibrils overwhelms the cell's autophagy lysosomal pathway, creating toxic clusters of failed autolysosomes around the nucleus. Monoclonal antibodies reduce the extracellular pool, however, they cannot penetrate the cell membrane. Internal panthos structures continue expanding, isolated from outside clearance. Once panthos is established, the neurodegenerative damage cascade becomes almost entirely cell-autonomous. The neuron is essentially dying from within. Intervening purely in the extracellular space arrives too late once intracellular proteostatic failure is established. The therapy must penetrate the cell to intercept the autonomous cascade. Simultaneously, Phase 2 is defined by the progression of intracellular tau pathology from Braak stage 2 to Braak stage 4. Transsynaptic tau propagation follows specific anatomical circuits, traveling via the perforant pathway from the entorhinal cortex into the dentate gyrus. This spread is driven by an enzymatic imbalance inside the neuron. Kinases like GSK3-beta become hyperactive, while the primary counterregulating phosphatase, PP2A, fails to maintain tau in its physiological state. Extracellular anti-tau antibodies, such as simorinalab, have consistently failed to halt this progression in clinical trials. If tau propagation relies on intracellular mechanisms like exosomal transfer or tunneling nanotubes, extracellular interception is biologically misaligned with the actual pathology. Correcting this spread requires pharmacology that targets the enzymes directly. PP2A activators like sodium selenate can restore the balance required to keep tau from misfolding. To halt tau propagation, pharmacology must penetrate the neuron to restore the kinase-phosphatase equilibrium before neurofibrillary tangles become irreversible. The Phase 2 collapse extends beyond the neurons to the vital supporting glial network of the hippocampal bridgehead. Myelinating oligodendrocytes carry the highest iron burden in the central nervous system, making them uniquely vulnerable. When amyloid stress depletes the protective enzyme GPX4, these iron-loaded cells are pushed past the threshold of ferroptosis, iron-dependent lipid peroxidation that destroys the lipid membrane. This necrotic myelin debris, combined with amyloid and tau, acts as a field of damage-associated molecular patterns, or DAMPs. Chronic exposure to these DAMPs forces the brain's resident immune cells, the microglia, to shift from their homeostatic surveillance state into a disease-associated post-homeostatic phenotype. Targeted pharmacology for this transition uses kinase signaling modulators like masitinib to keep the microglia in their beneficial homeostatic state. Simultaneously, nutraceuticals like N-acetylcysteine and alpha-tocopherol provide the specific antioxidant support needed to defend oligodendrocytes against pheroptopsis. A phase 2 intervention strategy that protects neurons but allows the supporting glial architecture to burn down will inevitably result in circuit failure. The phase 2 architecture is defined by amyloid clearance, tau propagation, iron-mediated pheroptopsis, and the microglial transition occurring simultaneously. The 35% efficacy ceiling represents the mathematical limit of treating a four-front biological war with a single weapon. This Gantt chart contrasts the current monolithic drug approach with a phase-matched combinatorial strategy. Instead of a single agent applied late in phase 3, we see anti-amyloids, kinase inhibitors, and pheroptosis modulators overlapping precisely during the phase 2 window between ages 50 and 65. This is temporal pharmacology, the art of deploying the right mechanistic intervention at the exact biological moment in the disease cascade. Cancer was transformed from a death sentence to a manageable condition only after the adoption of stage-specific combination regimens, neoadjuvant, adjuvant, and maintenance therapies. Future clinical trials must abandon phase-blind enrollment and implement biomarker-stratified adaptive platform trials to assign patients based on their biological stage. To conquer the hippocampal bridgehead, the field must shift towards precise temporal pharmacology, intervening before the circuit undergoes the terminal collapse of phase 3.